The topic of our panel now, we're going to turn to a different kind of set of stakeholders here. In our first panel, we heard a lot about the situation from those groups that are designed to be kind of helpers, navigators, support organizations in many diverse and complex ways. Now we want to move to the provider perspective, actually a set of provider perspectives. And we're going to, in a couple steps, get to the real nub of this, which is how do these high out-of-pocket costs ultimately affect clinical practice and ultimately including clinical decision-making and patient outcomes. So I know we talked about a lot of financial stuff and financial strain and hardships and so forth, which are bad enough for those who are affected. But does this stuff actually filter into clinical choice making? Does it actually have an impact on outcomes? I'm going to ask each of our panelists, starting from audience left to right, to introduce herself or himself, name, title, affiliation, and how it is that they find themselves on a panel on this topic. And we'll start at audience far left with Erin.
Hi, my name is Erin Hughes. I'm a financial advocate at Abington-Jefferson Health. I deal with the injection and chemotherapy of patients in our practice. I help assist with financial assistance for copay assistance through drug companies and also foundation assistance that is greatly needed for our patients.
Great, thanks very much, Erin. And Peng.
I am Peng O'Grady. I'm the Administrative Director for the Oncology Service Line at Abington-Jefferson Health. We're a 2,200 patient cancer program. We're situated in the far northeast of, right outside of Philadelphia. Our affiliation is with Thomas Jefferson University Health System, and our goal really is to build the Asplin Cancer Pavilion, which is a medical home model for cancer patients. So patients will receive their surgical oncology, medical oncology, radiation therapy, and interventional radiology care all under one roof. Our concept is a medical home model. Jefferson has a gorgeous oncology care model, and we're actually using that to build this new cancer center, which opens July 2nd of 2018. So Erin's role cannot be underscored or underplayed in any way, shape, or form. We've actually built 2 financial counselors within the cancer program now, because we know when we move from very disparate divisions to one hub that we're going to need extraordinary financial counseling and support to really guide our patients through the system from first diagnostic phone call through to survivorship.
Great.
Thank you.
Thank you. We have a good 1-2 punch then from Abington. Excellent.
Hi, my name is Eileen Peng. I'm the Director of Pharmaceutical Services for Regional Cancer Care Associates. Regional Cancer Care Associates is a pure community oncology network. We cover 3 states, New Jersey, Connecticut, and Maryland. So I live in a world that I'm between the pharmacy, the physicians, and the patient. So the copay, the out-of-pocket is my day-to-day life.
And thank you. Eileen is particularly well positioned to see this from multiple perspectives. That's great. Cesar.
Hi, my name's Cesar Santamaria. I'm a breast oncologist at Johns Hopkins. My specialty is in the care and treatment of patients with multiple types of breast cancers. In my day-to-day practice, usually I'm not privy to all what goes on behind the scenes in terms of getting patients scheduled and insurance clearance and whatnot, but certainly I do see the downstream effects when that doesn't go smoothly, which can manifest itself as delays in getting test results, rarely but sometimes thinking about alternate treatment plans and so on.
Excellent. Thank you, Cesar. The topics we hope to touch upon in this hour, I don't know if we'll get to all of them, but approximately this order: how do we identify the people that are in need? That is, who could be in trouble here? Again, from a provider standpoint, how do you as providers convey financial risk and how to kind of deal with it? Again, from the standpoint of providers. including things like toxicity and all those things that may pop up. How then might this or does this affect clinical decision making, followed obviously by how might this affect patient outcomes? Another aspect is, what about the interaction between providers and patients? I mean, there are a lot of things that we're demanding of our providers here. Does that affect their interaction with patients and their ability to deliver high quality care? And then I'm going to ask again about trend. This may come up in the middle of the discussion as well, but like where are we headed lately with all this kind of stuff? So, Erin, why don't we just start with you? I mean, you're on the ground there. I mean, do you have your antenna out for patients that might need extra help along the way with financial hardship?
Yeah, we do. So every day we are reviewing all the infused patients who are coming in. We try to be a few days ahead. So we're reviewing, verifying their insurance, and looking at their benefits. And we do this if the patient's coming in twice a month, once a month. So it gives us an opportunity to start from scratch, per se. The patients coming in, we're reviewing benefits and their out-of-pocket expense. We're finding that about 90% of our patients have no idea about their medical benefits.
Just 90%?
About just 90.
Wow.
It's very rare when I begin a conversation with a patient saying, how much do you know about your insurance coverage? It's very rare that they say, I know I have a $67 $100 out-of-pocket maximum. They usually say, I have insurance. I have insurance. It's taken care of. So we start from the ground up and meet with patients, the new patients coming in, and explain to them that you have a co-insurance or you have a copay, you have an out-of-pocket maximum for the year. This is what is expected. From that point, and these are patients that clearly are struggling. They have a lot on their plate. Some of them are like, I don't even want to hear about it. I can't meet with you just yet.
Erin, do you know that as soon as they walk in the door? Because the way you raised this was more, it didn't sound like you were responding to a patient complaint. You seemed to be more proactive to kind of look at the finances right away.
Yes, we're trying to be proactive to eliminate later on a complete shock to the patient. So we have just found it very beneficial to meet with them from the very beginning, whether that's their first consult, if they're ready for that conversation. Otherwise, we can meet with them at another appointment, or we can call them on the phone and just get through it's a tough conversation.
But for you, it's top of mind, it sounded like from the beginning, not waiting for them to express.
From the very beginning.
Peg, can you add to that?
We've been really fortunate. We've been able to use several tools, one of which is called CareVive, and it's a simple distress monitoring tool. So as patients are entreed into oncology, they're filling out their own self-assessment.
What's it called again? I'm sorry.
CareVive, a product built by 2 nurse practitioners, so near and dear to my heart. But what they've developed is a tool where it's truly the patient's top concerns and fears and anxieties and barriers. We've been able to use that tool quite successfully to say, finance, finance, finance. Everybody seems to be worried about it. If that's a general theme, then we have to get the right people on board to be able to assist and support. So whether that's a conversation with a social worker, or I really lucked out and have a social worker / financial counselor to my right, that conversation has to happen. Better it happen now than when a patient gets a $90,000 bill and we put them in complete shutdown and they've decided not to come back for care.
Does that actually happen?
Oh, absolutely. We've had patients, and I can't say at the institution that I'm currently at, but I can say at other institutions throughout the Pennsylvania area for sure. We have patients who are so completely overwhelmed with psychosocial, financial, how do I tell my kids, can I ever work? That it's completely numbing to them. Wow. And then we have to try to retrieve that patient appropriately. So our thought process with Abington was, we have outstanding staff who already work either in a social work realm or in some type of pre-auth, pre-cert financial realm where they can do the education, assistance support from the get-go, and honest to God, you see shoulders just, okay, I can breathe. Yeah, and that's our goal. That's what we really should be doing.
Great point. So Eileen, from the standpoint of running a pharmaceutical service, how does this manifest to you?
So I'm just going to start how our process from the day the physician meets with the patient, give them the bad news, and tell them what's the treatment I'm going to give you. So they will enter a treatment care plan in the system. From there, then our financial counselor would have a queue that this patient gets treatment. So they start to do benefit verification. At that point, they will call the patient and say, this will be your responsibility every time you come in, and what's your out-of-pocket. So they explain this on the phone in detail. Everybody in agreement. Then they would notify our scheduler. Then they would call the patient and come in for treatment. We schedule the treatment. Then we also have a program that will verify insurance 2 days before the treatment, because we all know financial, any patient can lose their job or go on disability, insurance change. So at that point, then they would write a note for our front desk people to tell them when the patient comes in what's needed to be paid. This is their copay. This is their responsibility. So now I think the hardest job is the front desk people. Now the patient, we actually have to hire a group of marketing people to teach them how do you tell your patient. You have HIPAA, that concern, and you have patient emotion. So they would say to the patient, this will be your responsibility. And even that, we also have something in place. Anybody, they have to come in, pay more than $500. They will get a phone call from our outsourced billing company to inform the patient, remember, tomorrow when you go into your office, your doctor's office, you're going to have to pay this money. So I can tell you, a lot of patients would come in and have no idea what you're talking about. And they would tell our front desk, nobody told me that. I don't know that. Where am I getting this $500? So now what do? Do we let the patient in, or do we tell them, I'm sorry, you have to pay? Bottom line, we're still oncologist's office. We need to take care of our patients. So now we have to create another position. So when patients really don't understand their bill, don't understand their responsibility, we would meet with them. But with all this, we always call and find money for our patients. Like, we try not to have them pay more than $200, $400, even $50. Some of them I just can't afford that. So this is the infusion side. For pharmacy side, we have a policy. Anybody has copay more than $10, we start looking for money for them.
You brought up a point that had never occurred to me, which was the fact that a patient is going to be undergoing chemotherapy may change his or her financial status right there. Even before they paid anything, it's going to be time off of work. It's other things that change their, I think you might have even said patient in motion. There is a change right there even before they get care. They're in a different financial place now as a result of this.
They're very, very anxious. So patient would say, I know I can come to your office for treatment, but can I go to hospital? Because I can't afford losing workday. So that's how we have to then help them schedule treatment at the hospital. But then they face another financial burden. Hospital charge could be higher. So then we would say, yes, I can do anything for you that way, but you need to make an appointment with the hospital financial office. Go through your financial burden right there.
You made a couple references just now to something that sounds like having to invest in new FTEs and or contractors. Did I hear you correctly?
Yes, because it's necessary services for patient. For community oncology office, we don't get any reimbursement for social worker, and but we need to spend this money to make sure our patient get taken care of. Then we can keep our doors open.
So even as skilled as your existing staff may be, it sounds like you can't get around making an investment in staff and or contractors.
Right, and we, it's a very complicated process for a patient that just got, they got diagnosis with cancer. It's already a very, they get very anxious with everything, my job, my family, my financial status. So from day one, we actually have a chemo teach from our mid-levels. They will meet with the patient. This is after the physician, right? Physician already sat down, explained everything to the patient. Then we set up we have a financial counselor call with the patient. Then we set up a mid-level chemo teach, meaning we would explain to them, when you come to treatment, what happened and your financial and what's, the whole process. So then afterwards, you have to have a nursing navigator, because we don't really have that position called nursing navigator, but somebody in the office need to play that role.
This sounds like a great accomplishment, but also sounds very complicated, and a lot of people are involved. The timing and the flow of all this sounds, to me, daunting as a non-clinician. But
Absolutely. So we actually train our physician, please do not talk to your patient about any of this, because you are not trained, just medical. And we don't want your patient, because our patients say, our physician used to say, don't worry, someone will call you, you get your treatment. And we're like, no, you do not say that, because they might not be able to get treatment in our office. They might not be able to afford.
Cesar, did they tell you to be quiet about this? How do you handle it?
Certainly not directly, but
Behind your back.
I mean, the truth of the matter is, again, a lot of the behind-the-scenes things I'm not directly involved with necessarily, but I certainly see the downstream effects. I think just to take a step back, and something you were mentioning is, when a physician tells you you have cancer, that's one of the most difficult things to hear. And it's really something that affects your life at multiple levels, not just yourself, but your family, your friends, your social network, your job, and there's many factors that can affect your ability to receive treatment, transportation, childcare. So being able to get your drugs is one aspect of it, certainly, and an important one, definitely not the only one. And so that's why, as a physician, I very much rely on my social work team, on financial care teams to kind of help patients navigate through that. But I think it is important to understand it's really a multiple variables that play into patients being able to receive their care in a timely manner and in an effective manner.
Cesar, granted, there are other people on your team and in these institutions that are looking for this, but as a clinician, as an oncologist, do you look for certain signs or risk factors that might tip you off to the need for this kind of intervention?
So I just want to clarify, as an oncologist, when I have a patient and I'm developing and recommending a treatment plan, I do not consider, if you'll be able to afford it necessarily. I'm going to recommend what I think is best for you.
We're going to come back to that, by the way, but go ahead.
Yeah.
Okay.
I am going to talk to them about what I think is best for them, and I'm going to put pressure on my financial team and social works to help me achieve that plan. Not so much the other way around. I can't, based on when I see a patient, say, oh, well, I'm not sure you'll be able to afford this drug. No, I'm just going to recommend what I feel is the right thing medically, and then work the best I can with my team members to achieve those treatments. Many times that does require writing letters and whatnot, and I do that part I am involved in many times, helping with pre-authorizations or fighting back insurance companies and things like that.
Is that a small part of your job or a larger part of your job these days?
I would say it's the part of the job that spills out of clinic days. I have my clinic day, I see my patients, finish my notes, but then I get the faxes, throughout the week saying, for example, and again, it's not just treatment. I think one of the prime examples I have is with certain diagnostic testing. In certain early breast cancers, will order a gene expression profiling to assess the need for chemotherapy, for example. and this is an approved standard of care test. You know, this has been validated. It's part of standard practice. But even though I'm recommending it in the approved scenarios, many times I'll get these faxes saying, you know, can you please add these additional information, you know, or, you know, this wasn't initially approved. Can you call back and talk to us about it or something? And those kind of things delay therapy.
And you're still dealing with that. Okay.
Yeah, I do deal with that directly.
What are there other lessons or gems of experience that any of you can convey with regard to how you share this information with patients, how you communicate with them, how you listen to them, how you interact with them, how you deal with the, you know, financial toxicity? What else have we learned about how to do this better? Erin, you want to take a try at that first?
To do it better,
What seems to work?
I would say to honesty. And
Honesty.
patients often struggle with, and I think it's just people in general, talking finances. So from the beginning, when we meet with the patients, it's everything is private. Your information stays between our walls. I think they just often need to know that their information is safe and secure with us, that their debt, because they've had to miss work, or their spouse is now not able to work. People are so private about their finances, and we respect that to the utmost. And we need them to be honest with us so that we can then provide additional supports for them. So that's just something that there's two of us, there's two financial counselors, that we try to begin the conversation with our patients. Nothing that they will tell us would shock us. We don't judge them. We're there to listen, and we want to find a solution for them financially to the best of our ability. Find options to help pay with their to help pay for their chemo.
Honesty, and as you said earlier, being proactive, preserving privacy, and offering informed options. I mean, it sounds like those are the things that you can put forward. Peg, from the stand, I mean, you're an administrative director of this stuff. What else do you think works in these circumstances?
We started very early on to look at best practice methodologies. So there were 3 camps of experts that we really tapped into. The Association of Community Cancer Centers runs a boot camp for financial counselors. Awesome. Free. Free is good. So we were able to enroll our staff early on, get the education and training that they really needed, and that would supplement them. But more important, that's a network they can tap into for any question and answer that they have. And believe me, they all connect. Whether you're in California or Philly, you're going to connect because you have to. You're constantly searching. Erin is part detective. She is searching for resources like you wouldn't believe. The other group was SG2. They gave us 10-year strategic planning, and financial counseling was a piece for them 15 years ago. So they were pretty forward-thinking. And then the third is Oncology Roundtable, and to me, they gave me best practice sites that we could tap into where we could actually sit down and via video conference go, okay, tell me about your barriers to your program, what worked, what didn't, and why.
So there's a network of best practice sites for information exchange on how to do this?
Absolutely. And everybody's different. You can go to a 60-bed hospital. You can go to a full-blown health system with, 70, 80 institutions. They all do it different because your local community is different, and that's who we serve. We serve Abington. We serve Jenkintown. We serve Glenside. Those are the areas that we target. So you do a great community needs assessment, and you find out what your community needs, and then you backfill with the resources to really make that happen. That's how you take care of your patients in your community, and quite frankly, that's how they stay.
So we're hearing honesty, proactivity, preserve privacy, be a detective/resource finder, learn about best practices more broadly, yet remain rooted in one's community.
Exactly.
That's what we're hearing. Eileen, what can you add to how we know how to do this better?
I think we need to spend more time education patients. They are really lost. And even providers, they need to be educated, because I think physicians in the past didn't really realize all this financial toxicity. They don't understand. And, oftentimes I'll get an angry email. What happened to my patient's treatment?
But hold on, just before you go on. Patient education, you're the one who said they're overwhelmed. They're having a
Right.
hard, how do you patient educate in that context?
But it's an important education. I think we open our door and meet with them, to go through the education process from the time, how do you plan your financial? How do you work with us to find funding for you? How do we actually prepare a list of all the assistance around transportation. If you need it, this is the number you can call. And it's important. If you need cleaning for your house, this is the number you call.
Really?
So we actually compile a list out there for them to know to call. If you need a companion who you can call to talk to. There's a lot of resources out there. We just need to guide patients to do and help them. We would sit with them and fill out the forms.
So this is so helpful because, again, our keynote speaker elucidated all the things non-medical that impact patient risk and distress, and you just rattled off a few that she said by being able to be a resource finder along those dimensions.
Right.
So it's not just about the medical.
No, because, again, we talk about financial toxicity. You need food, you need lights, you need electricity in your house. There's different funding and different organizations will help. Some of them are local, some of them are national, and people don't know. And when you're so anxious or, already find out you have cancer, the whole family is under stress. Give them the information, hand it to them, and help them out so they don't have to go online and search.
Are patients doing better, patients and families doing better as a result of this guidance and information support?
I definitely feel so, because this will able to help us to calm a lot of angry patients. Because they
Angry?
because when they realize I got sick, now I have to pay all these bills, they kind of transfer that anger to providers.
Really? So
Why are you charging me $5,000? How much money are you making out of this? But they don't understand oncology is one of the services that you pay upfront, right? Providers pay upfront. Pharmacy, we pay upfront. We have to pay money to get drug to our patient.
So this was not on my list of questions, but
Sorry.
no, Peg, is dealing with patient and family member anger an issue?
I think it's totally dependent upon the family dynamics. And that's actually why we have social work in play in conjunction with our nurse navigators. So what I would say is patients go through grief steps. And I think the first is the shock and awe of the diagnosis. Certain people will get angry. The family is desperate to help them in any way, shape, or form that they can. So I totally agree with the discussion of give them information, do it proactively, tell them there are resources that they can tap into, and then let the family start to work through that process. But there's this adaptation phase that goes through that is frightening and angry, and finally you hope they get to the point where they adapt into the new normal, but it's not the same normal they started with.
Wow. Dr. Santamaria, you alluded to this earlier. I want to paraphrase what you said and tell me if I'm playing this back to you correctly. This is the essence of what I thought I heard you said. When I make clinical decisions with and on behalf of my patients, I pay no heed to the financial implications. I try to find them the best clinical resolution or therapy possible, notwithstanding finances. Is that accurate?
I would say that's accurate, yes. I mean, when I have a patient, first of all, I don't have access to their financial records when I see them in clinic. You know, I see them with whatever diagnosis they're coming with, I evaluate them, and yes, I'm going to give the recommendation as to what I feel is best for them.
Okay, now what happens when these financial hurdles arise and you didn't know about them a priori? Does that now affect clinical choice making with the patient?
It can. I think the most common manifestation, what I see trickle down, again, and I'm not involved in a lot of the behind the scenes things, so I can't really speak to that, but usually it manifests itself as treatment delays.
Delays?
You know, many times I am able to get what I want to give them. It just takes a long time.
Because you're having to justify it, or what?
Because I'm dealing with insurance companies and writing letters and prior auths and this and that, and it can sometimes result in treatment delays. It is rare, at least in my personal experience, that I've actually had to change the treatment plan. And the one scenario I see that playing is, for example, in when I treat patients with metastatic breast cancer, where we're sequencing different chemotherapies or different treatments in order to prolong life. Unfortunately, not a curable situation. There are sometimes oral therapy options, and there's IV therapy options when it comes to chemotherapy. And sometimes getting the oral stuff is challenging, and I'm sure these guys have a lot more to say about the behind the scenes of that. But and so I have had situations where I would have liked to go as a next line therapy with an oral option, but because there's too much of a delay, I'm going to an IV option.
So the delay so you start out saying, from a medical standpoint and the best clinical practice guidelines, this is the right therapy for you. That's your point of departure. Sometimes because of pushback by the insurance side and others, there's some delay. And then beyond the delay, you may be forced to make a choice between, let's say, oral and IV, for example.
At some point, you have to treat the patient in front of you, and
Okay.
you have the tools that you have. And whether, you may have liked to pursue with one line of treatment is one thing, but, if you can't get it, again, I still have to treat the patient who's in front of me. And that's usually when the angry emails come out. But, I think that is definitely one of the times where I see that manifest.
Eileen, how does it work?
So I think I can give many examples.
Give us maybe one good one.
So one very recent one is our physician recommended injectable for one of our ITP patients. So our financial counselor did the calculation, talked to the patient, and the patient's copay is responsibility is $250 per treatment. So the patient did some search herself and came back to our physician and say, there's an oral medication that I can take every day. So what's my option? So we get a call from our physician, send a prescription to our specialty pharmacy. The copay came back at $50. But don't forget, when I say $250, it's not just $250. There was foundation money that we have to apply for to bring it down to $250. The $50 for the oral prescription also involved with some copay assistance. So that's tons of work for the infusion team and the oral team. So then we have to present this case back to our physician, and our physician goes, let me talk to my patient. Then he went back and talked to the patient. He preferred to give her the injection because of adherence issue and the toxicity profile. So the patient now say, let me think about it. Don't start any treatment. Don't send me prescription. So then we all put on hold, waiting for her to make decision. A week went by. We have to call her back and say, so what did you decide?
You called her back.
No, our physician has to be the one because, I'm a pharmacist. I can't make
But
treatment
she didn't call
decision.
your outfit, your clinic. Someone from your clinic had to call her.
Right, because
okay.
she's still thinking, should I pay $250 or should I pay 50?
So,
Can I add one more case?
okay.
So then
Yes, Eileen, go ahead.
our physician likes to do, give patient infusion. Then there's a pump involved. Then you have home care involved. Then the copay home care will say, I can't cover this patient. Should this patient go to the hospital, or the physician should change the treatment to oral? Now, oral drug now has no copay assistance. Now we got to find the funding for the patient. The funding for certain disease is very low. So we all stuck there, don't know where to go.
There's a lot of scrambling going on, Eileen, to make this. I mean, it sounds like Erin's full-time job is scrambling for stuff, and you're scrambling for solutions. Peg, I wonder from your standpoint of overseeing kind of an operation here, have patients ever said, I'm done, I don't want to do this, even though Dr. Santamaria might have said this is the best thing for you clinically, might a patient say, yeah, but I just can't handle it and the financial burden's too high, let's stop, or I want to go to a much different therapeutic option?
Sure, and the one thing you have to take into account in these conversations is it's always the patient's decision and the family's decision on how they want to best move forward. But you have to have the right information at your fingertips to say, this is a curative intent, we plan on you being here a lot longer, versus this is a palliative intent, we plan on maximizing as much support as we can give you to keep you with good quality of life and comfortable through your process and transition. Those are the things that you need to be able to explain to a patient. And I do believe that if the patient, I'm going to give you a Disney example. If the patient sees a clinic that operates well, they're hearing it's a small world after all. The back end might be going crazy, but they don't see it and they never should.
Oh.
Honestly, I mean, if you run a smart clinic, it's how may we help you? What can we do to get you where you need to get to? Guess what? We have services. Let's tell you what we have to offer you up front. We're going to put it in writing so that when you go home, because you can't breathe right now, you're going to be able to sit down with your family and go through what the options are. And I want you to refer back to this information. If your insurance changes, you can still breathe. It's okay. We're going to find a way to be able to work with you, whether it's a sliding scale payment or other assistance and support, or we are unbelievably generous in the Abington community. And if we are really in need, we use philanthropic resources all the time to be able to benefit the patients that live in our community.
Well, then let me ask Cesar, Peg just said, talking about a therapeutic route and a palliative route, is it ever the case where a patient could go down either route, but based on finances makes a choice in a certain direction? Maybe
So, yeah, I will say this can vary on the type of cancer. So I'll speak to breast cancer, which is what I specialize in. There's early stage disease where the approach is to achieve cure, and then there's late stage disease when it's spread in different parts of the body. It's not curative at that point. The treatment is palliative. Typically in breast cancer, we do catch patients, fortunately, many times at an early stage, and overwhelmingly, the impetus definitely is to be aggressive and try to achieve cure. There are certain situations where, due to social issues, patients aren't able to follow up, or they're not compliant with treatment due to the circumstances that they find themselves in, like transportation, childcare, or whatnot. And then, unfortunately, many times, because they received inadequate treatment, they can present at a later time point with non-curable disease.
Well, hold on. Transportation and child care hurdles might affect their prognosis?
Their ability to come for treatment, and there's many factors. It's not just that, it's work, it's who they have in their family to help with, routine things. I see this, unfortunately, obviously this affects people who don't have as much resources, who have more limited social networks in terms of the support they can have, in people who are poor, particularly when, they may not have insurance or I was in practice in Chicago for several years, and in my practice I did have a lot of patients who were undocumented immigrants, and they had very, very limited resources, and these are the at-risk populations that that really we struggle with in trying to get them through curative treatment to avoid a non-curative situation.
So their financial status and the financial toxicity can have an impact on access, adherence, and sometimes they drop out, it sounds like.
In a broader scope, yeah, because again, not necessarily the price of the drug, but all the other aspects that surround
Transportation,
cancer
child
care,
care,
et cetera, yeah.
Okay, so therefore, can anyone on the panel speak to the matter of, does any of this translate into suboptimal patient outcomes? Does it ever, can you say that it really affects mortality, morbidity, quality of life? Cesar, Cesar, then Peg?
Yeah.
Go ahead.
So, I will say, it's not certainly the typical situation that I end up seeing in clinic, but I would say any level of that is really unfortunate, is unwarranted.
Does
in my
it exist,
opinion.
Cesar?
It does exist.
Okay.
It does exist. Yeah. Does it exist? Yeah. I think all of us who are in healthcare have seen situations like that, and it's again, unfortunately, in minorities and people who don't have resources, things like that.
Peg, Erin, and Eileen, on this issue of impact on outcomes, please.
Sure. So the impact is gigantic on the patient and family, and that's who we treat every day. The impact on population health is, are we targeting upfront the right communities that need to have perhaps more upfront screening, more, meals on wheels for good nutrition. So if you look at cancer as solely treatment, I think you're missing the boat. I think you really need to look at the screening intent, the healthy behaviors, the great opportunity to keep a community healthy.
A wider focus then.
Yeah, absolutely, because it's a trickle-down effect. If you're not feeding the community well, they will get chronic disease. It's just a hands-down fact. If you're not able to appropriately educate the community on what screenings are appropriate and vital to them based on family history or community benefit, then you haven't done the service to the community. So, one of the things that we're hosting as we open the new cancer center is the day we open, there's a community day event on a Saturday with 7 screenings. We plan to be their medical home. We want to take care of them from, the first screening they get for cancer through their entire lifetime. And I think that's the type of medical home that a community is proud of.
Okay. By the way, we're going to go in a few minutes to audience Q&A, so if you have a question, if you want to get queued up, please do so. Raise your hand so that, I see a hand raised already in row 1, 2, 3, 4, 5 over here, so that someone might can come to you. But first, Erin and then Eileen on this matter of ultimate impact on outcomes.
I would say there is an impact. I probably hear a lot from my initial conversation with patients about these extra needs, the child care. Thankfully, we have and many other issues. We have a social worker that we rely on very heavily, and she is always tapping into outside resources, whether it's the person's church to provide childcare. She works tirelessly to find options so that patients are not foregoing their treatment
Okay.
every single day.
That's her job.
Yes.
Got it.
So we work very closely together. So if during my initial visit with them and they start talking about their finances, they start talking about their struggles, I quickly can send her an email, meet with her, and say, this patient needs you. Like
And the
early
earlier
stages, earlier the better.
the earlier the better, including not just for the clinical reasons, but even for financial, you can kind of tune into, it
Right.
sounds like, awareness of their financial risk.
Yes.
Eileen, on this issue of ultimate impact on outcomes.
So financial toxicity is one of the top reasons for adherence issues. So that's for sure. We have patients that, don't take their pills following the instruction just to save their copay. And that's when one of the jobs that for us as pharmacists, when we call patients for the next shipment, we have to call them on schedule and ask them how many pills you have left. We need, like adherence leads to good outcome. Otherwise, it's waste of money because the treatment is not going to get to the outcome you needed.
So I'm just, as an observer, just very impressed by the need for proactivity here. Each one of you has said something about thinking ahead, anticipating, getting started early, not waiting until that moment where they know that they've got cancer and they just dump this whole thing on them. You seem to have your antenna out for coping with this issue as early as possible. Peg?
There's one more group that I think we need to take into account here, and that's the primary care group. I can't tell you how valuable primary care has been to our cancer center. They fed us through things like lung CT screening and smoking cessation, making sure their patients are getting their mammograms, making sure they're getting their colonoscopies, bringing us in when they have such a complex patient that they're just not sure. So, prior to even a cancer diagnosis, they might bring the cancer program in and our experts in for additional assistance and support to be able to guide that conversation early. On the back end, we're handing them off survivorship care plans. We have a connected medical record. Oh boy, is that important because everybody's on the same page and they can talk to each other. So those are the things that I think, primary care and cancer have to go hand in hand in order to get a population benefit and in order to make sure that we're taking care of patients at an earlier stage of disease.
Care integration, thank you. The first question here, this is the woman from Detroit, I believe.
So every decision I made.
Can you say your name one more
My
time?
name is Molly McDonald, and I'm a founder of a national organization called the Peng Fund, which makes 90 days of non-medical bill payments for breast cancer patients in active treatment to their creditors for housing, transportation, utilities, and insurance. We started out of my kitchen, and we've paid close to $2.6 million in the last 10 years. So we're tiny. But every decision I made around my treatment was based on money. So I didn't have reconstruction because I couldn't afford the copay. I also couldn't afford the risk of infection and hospitalization. When the doctor recommended tamoxifen, I couldn't afford $300 a month for the pills, so I was enrolled in a clinical trial. Well, the problem was I didn't like the way I felt. The clinical trial did not include the cost of the other medications to counteract the way I felt, so I dropped out. I dropped out. I'm alive. In my experience at the Peng Fund, we have met with women who stop treatment because they can't stop working. And in fact, one of them was a bus driver. Somebody talked about a bus driver, elementary school bus driver. She stopped treatment. She could not work, and she died.
So wage loss or the potential of wage loss steered her
huge.
Away from care.
You can negotiate. I negotiated all my copays with the hospital. It took me 3 years to pay it off. I paid $50 a month over 3 years. I was still trying to get back to work. I did it in writing. I didn't have a credit card, so I couldn't put it on a credit card. My house was in foreclosure. I had no liquidity of anything. But it's this lost income that compounds that problem. The hospitals will help you with the copays and the deductibles. On another totally separate thing, my daughter had a really crazy accident in April. And she was taken to Cedar-Sinai Hospital. Her bill was $168,000 for emergency surgery. She lost her job. Her copays, her deductible was $6,800, and her copays were close to $30,000. She called me the other night in tears. She applied for aid. It was all dismissed. These are challenges that people face.
Thank you.
It's that lost income that really catapults you into that financial toxicity chasm.
And that's
Thank
actually
you.
something that our physicians do ask routinely as a patient starting treatment. I'll give you a great example. My sister got diagnosed with breast cancer. Jane absolutely had to work. There was just no two ways about it. I said, okay, I'll plea bargain with you. Old school, I used to give injections as a real nurse. I can do that on a Saturday. You can get chemo treatment Friday. And then you're able to continue and work Monday through Friday. And the physician went, absolutely, this makes total sense. Can you get the last appointment on Friday in that chemo chair so you can continue to work?
So there are some accommodations that can be made.
Absolutely. Absolutely.
Cesar on this?
I think this again really speaks to the multi-tier effect a cancer diagnosis has on an individual, their family, their social support, and the current system we have in place doesn't really address many of those issues, and we're scrambling. I think, as one of the comments in the previous talk was, we're patching a sinking boat, right? And I think in many ways that's absolutely true, and we need a new boat.
Build a new boat. As in we need a bigger boat. That was from a movie. Okay. Question 2, question 3, question 4, and 5, 6, if we can get to, we'll do our best. Question 2, sir. Name and affiliation quickly.
Dan Sherman, the Navectus Group again.
We love brevity now.
I'll try.
Okay.
So I love the conversation here about being proactive. Let me give you a quick example. A patient walks in to have surgery. Surgeon does what he needs to do or she needs to do, walks out, then the next person that walks into the room is the anesthesiologist, says, I'm ready to give anesthesia. Right? We don't do that. We proactively deal with the pain so that the patient isn't harmed. In the world of financial toxicity and distress, we do the opposite. We do surgery first, and then we provide the anesthesia by the financial navigators. And so it is this critical that the financial navigator is there first as is happening.
Good process point. Yes.
Right. And then, I don't know if it's a question, but for me, the best way to solve this from a patient perspective is, when we can patch the hole by doing copay assistance and patient assistance programs and charity. But if the financial navigator has expertise in health insurance, really understand Medicare and MSP and LIS and all of the different programs that are out there to improve their insurance.
Yeah.
Insurance optimization, now you've fixed it for the individual. And so, once again, I'm going to be preaching here that the financial navigator needs to have expertise in all of this stuff to proactively deal with it.
Got that. Thank you. Erin, did you want to comment on that issue briefly?
I completely agree with you. So this is a new program at Abington that we're doing, and with the 2 financial counselors. And my degree is in social work, so I can't say that I'm an expert, but I rely a lot on my community, and I'm constantly calling. We partner with Jeff, our model, our financial counseling model is off of Jefferson. So I call there and I ask questions. There's so much to learn that it's often playing catch up. Things change so quickly. So I agree with you 100%, and I wish that there was another program that, I could enroll in even to learn more, and it's ever changing.
Continuous learning, right?
Absolutely.
Okay. Eileen, briefly on this?
So we actually, every year in October, we will put out a sign and ask our patient to ask for help. Like we would sit with them and go through what are the financial, like the plan out there. But I think the tool, a Medicare tool, is very, very important because I don't think it's legal for anyone to recommend a plan to a patient. You can answer questions, but you cannot recommend.
Important technical point. Thank you. Question in the back? Briefly.
Okay. First, I want to say thanks for what you guys do. But I wanted to ask, does anybody really look at like a cost-benefit analysis? And I'll tell you what I'm thinking is people who if they don't work, they don't get paid. I talked to a truck driver recently, a bartender in Vegas, but also older people. I talked to a guy in January who summed it real well. I'm 89 years old. I may not make it to this phone call. He's trying to decide whether it's worth paying for adjuvant chemotherapy or not. So you may even look at that.
Yeah, it says actually the stuff in the news these days about stopping screening after a certain age of certain cancers. Go ahead, Cesar.
Sure. Yeah, I'll use the example given in terms of adjuvant therapy, and Absolutely. You know, I think that's something very much that we consider when we're optimizing our treatment recommendations. What's going to be the net benefit? Are you looking at, you know, a 1 to 2% benefit versus, you know, something more substantial? When I discuss that, I think it's important to understand that everyone's sense of risk is different, and that's something that's deeply personal. For some people, 1.5%, that's good enough for me, and I'm willing to go through heck to achieve that potential benefit. For many people, I would say most people, frankly, that might not be the case, but I think that's very much a discussion to have. And particularly, for example, in elderly patients or patients who have lots of other medical issues going on, many times, you know, doing the most aggressive treatment is not right. That's part of the recommendation, though, that balance. It's not necessarily the finance that's driving that recommendation. I think it's what the ultimate net benefit for the patient will be, right? It's not, you know, oh, you're 89, I don't think you'll be able to afford it. No, it's 89, I don't think you're going to have a benefit that would drive that recommendation.
There are, as you know, there are a lot of movements to look at cost-benefit or cost-effectiveness analysis, cost-utility analysis, ICER in the United States, a lot of health technology assessment agencies. U.S. Preventive Services Task Force has a form of that. They can't always talk about dollars explicitly, but they are looking at trade-offs, especially at end of life. Next question, the dude from Utah, I think. Okay.
University of Utah, again. I run a team of pharmacy technicians who function as financial counselors for cancer patients. We also are proactive. We're in the clinic with the doctors, and as soon as they decide on something or don't decide on something, they tell us to look into the benefit and perform analysis so they can go in with these conversations. And first of all, shameless plug for technicians, if you are looking for solutions that are inexpensive, pharmacy technicians have the prescription, the insurance background already, and are craving, in most cases, a chance to do more for our patients. So we're your huckleberry.
Okay.
And
your question.
My question in this is, there are so many groups, and I think we've ignored the other side, the back end, the claims billing, the coding specialists. We all have such different focuses. How do we build the buy-in and the collaboration between the provider, the financial counselors, and on the back end for when denials go through that shouldn't have, getting that resolved and having that clear communication and...
Peg, this is a systems question.
We have weekly meetings on denials, and that's to make sure that if there's anything that we can catch to benefit the patient, we do. I absolutely agree on techs. So our specialty pharmacy for oral chemotherapeutic agents is principally run with techs and a senior pharmacist. And they do extraordinary education to the patient. And they can do the pre-auth review very successfully. So I think those are programs that are unique and novel. They work hand in hand with my clinical nurse navigators who do all the diagnostics, follow through based on a physician prescribing oral chemotherapeutic agents.
Okay.
Yeah, so it's a village,
Good,
definitely.
thank you. We're going to try to squeeze in 2 more questions. There was one here and here, if I'm not mistaken. So, oh dear. Okay.
So
one, 2, and maybe 3. Okay, I'm going to do our best.
I'm
Brief.
Yeah, for Humana, to the panel. Do you think we are in a free market when Medicare cannot negotiate the prices and when physicians are not considering, and I'm a physician, cost when talking about treatments as an attribute, just like survival or the other side effects?
Okay, so let's take that. Are we operating in a free market environment? Yes, no. Let's be truthful about it. Peg, what is it?
I think we're getting there. Groups like the Oncology Care Model, where they're actually, one of their measures is to make sure that patients see up front what the cost of care is. That's pushing the issue significantly. And I think the work that's coming out of OCM is going to be really fascinating to find out.
OCM would be good. Now, remember, in our previous panel, we heard about what goes on between manufacturers and PBMs and others, that there are financial incentives at work that might not be truly reflective of an Econ 101 free market. But point well made. One more question, and then actually 1 and 2. We're all brief now.
Okay,
Go ahead.
very, very brief.
Robin.
Robin Yabroff, American Cancer Society. I want to thank you for a really fascinating panel. And I have a 2-part question, but it's quick. So my question to each of you is, what percentage of the patients you see do you spend some time dealing with financial issues? And then for those patients that you do see, how much time do you spend? So if you see 100 patients,
Erin, what percentage get this financial help, and then when they get the help, how much time? Put you on the spot
a
there.
very large population of who I meet with.
50%? 80%?
I would say 80%. And the amount of time I spend with them or dealing with their situation, it could be hours, because I'm constantly trying to figure out what will work best for them, or then if we need to do a financial application through the hospital because everything else has not worked out. It's constant, I need this documentation, follow-up. They're feeling terrible. They can't get to the bank to get bank statements. So it could be hours for patients. And then there's follow-up as well. Like application's good for 6 months to a year. We're looking back, getting back in touch with them.
So as many as 80% of your patients, and for each patient over multiple visits, it can be many hours.
Some resolve quicker. Some, I can find foundation help. Drug copay cards. That's on the easier side. I can't even say easy, but less time consuming. Patients with more of a financial need, I'm spending way more time.
Good. Thank you very much. Thank you, Robin, for the question. Last question. I think it's Lee. Hi. Last question.
Hi. I'd like to know how you...
Got to say your name.
My name is Ann Karish. I'm from the National Council on Aging. And to get my quick question in, I'd like to know what techniques you use, or how do you handle... I've seen patients glaze over when they realize they have a $1,000 copay or a $400 copay. How do they possibly recognize or determine what will impact them in terms of their life with a $10,000 or a $100,000 copay? How do you make that kind of distinction?
Peg or Erin? I don't know. Which one you want? Jump on that one. Erin, congratulations.
It's challenging, and we just discuss all the options for the patient. It's daunting. There are some patients, there's times I go into an exam room, a doctor will pull me in and say, come talk to this patient. There are times that they're not ready to discuss anything financial, nothing. Like angry, mad, I don't want to talk about this right now. And that's okay. So I give them my card, tell them where my office is located, please stop by. It's so overwhelming for these patients. And your heart breaks for them. I always try to put myself, this could be my mother, my father, my sister, my cousin, my friend. So it's often trying to make a connection with them and being honest. These are the options. They usually call me back within a day or two. It's a lot to digest. So
you allow them to kind of digest well and come back to you when they're ready.
They have to, and they dictate what they want. Some patients are like,
right.
Give it all to me right now. I need to know, what am I going to be paying for this chemotherapy? What is the worst case scenario?
So you're becoming flexible and responsive, appropriate to that patient.
Absolutely.
Any last word on this issue? I know we've got to close. Any last issue? Okay, thank you. I think we got to 7 questions or so. With regard to how do high out-of-pocket costs affect clinical practice and patient outcomes, a lot, apparently, in both cases. Erin Hughes, Peg O'Grady, Eileen Peng, Cesar Santamaria, thank you so very much for being straightforward with us, giving concrete real-world examples, and being real beacons of hope for how we will do this better. Thank you so very much. Thank you.